Welcome all to our HUR Australia webinar, Strength, Health and Wellness from Epidemiology to Service Delivery. It is a great pleasure to welcome you all one more time to our final 2020 webinar. To listen to our guest speakers who yet again have amazing messages to share with you all. In the spirit of reconciliation, HUR Australia acknowledges the traditional custodians of country throughout Australia and their connection to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. My name is Tora Karahari-Huisman and I'm from HUR Australia and I will be your MC today. It really has been quite a privilege to host these webinars throughout this quite a challenging and interesting year of 2020. I'm so grateful to all the speakers we've had throughout the year. We've had four different topics every single webinar, so a total of 12 specialists sharing their knowledge. I'm also equally thankful to absolutely everyone who's joined us throughout the year. If we count every registration and every view on our YouTube channel, we have reached almost 1,500 people all around the world. We're covering 18 countries with the webinars, and really our audience has been varying from allied health professionals to managers to just people who want to look after themselves and hear the best messages and instructions on how to stay healthy in these challenging times. I'm thankful to everyone for your interest and participation, from speakers to the whole audience. Our final webinar today has another lineup on absolutely fantastic speakers and topics. We have Dr. Jason Bennie from University of Southern Queensland discussing exercise epidemiology, Allan Zhang from the Selwyn Foundation in New Zealand sharing some case studies, Nathan Hall from the BaptistCare at Home discussing care models and innovations. Finally, Daley, the CEO of Integrated Living, discussing the creation and management of health and wellness delivery throughout Australia. Now, before we start, a few house rules. I know if you saw the slides before, but during the webinar, all your attendees' microphones will be muted and your cameras will be disabled, so we can't see or hear you. However, you have one very important task to do during the webinar, as you are there to ask all the questions. So in the bottom of your screen, you will have a little Q&A button. That is where you can type your questions to all our presenters. Now, there is a chance that we can't respond all of them because there's only a 5-minute response period or the Q&A period. But we'll try to answer some questions live, but anything that we don't have time to, we will type the answers and we'll share all these answers on our website together with the recording. The other thing is there's a little thumbs up button. That means that you can vote on a question. If you can see a question that you really like and you think it's important, push the thumbs up button, and then that question will rise up in importance, and I will make sure I'll ask that question. Also, the webinar will be recorded. We are now in summertime and Europe is in winter time, so the time difference is 9 hours and it is 5 a.m. in Finland. So we will let you guys sleep in. So we'll record this and you will find the recording and all the slides and all the Q&As on our webinars website. One final thing, if you hear this bell, it is nearly time for Christmas. So for once, my reindeer is in a timely manner. This is just a sign for our speakers that their time is almost up. So I will give them a 5-minute sign and a 1-minute sign, so we'll stay nicely in time. Without further ado, it is time to welcome our first guest. So Dr. Jason Bennie is from University of Southern Queensland. Jason leads the muscle strengthening exercise epidemiology theme within the physically active lifestyles research group at the University of Southern Queensland. Dr. Bennie's research focus is on physical activity epidemiology with a particular emphasis on muscle strengthening exercise for chronic disease prevention and management. Dr. Bennie has published over 60 peer-reviewed journal articles, and with COVID still going quite heavily in Europe, there's more time than ever better than listening to Jason. So Jason, you have your 15 minutes. Thank you for joining us. Jason, you're on mute.
That's not a good start. Okay, I'd like to thank HUR Australia for allowing me to present some of my research, or asking me to present some of my research. I'm looking forward to listening to colleagues as well present their research. So as Tuya said, I work at the University of Southern Queensland, where I lead a research theme around muscle strengthening exercise epidemiology. And today I'll be providing a really brief overview of my research program and a bit of a background and some of the main studies and where we hope to go with this type of research. Okay, so the Global Physical Activity Guidelines have been predominantly based since the 1970s, so it's around about 40 years, getting up towards 50 years now, primarily based around aerobic physical activity and the accumulation of 150 minutes or 75 minutes, the equivalent combination of both. More recently, muscle strengthening exercise has come into the guidelines. It first came in 2008, and it was part of the American guidelines. The WHO adopted them in 2010, and Australia were a little bit slow on the uptake. We adopted them in 2014. So my research program predominantly is based around muscle strengthening exercise, and I'll talk about definitions and health outcomes in a sec. So what do we mean by muscle strengthening exercise? Well, it hasn't really been defined properly in the literature because of the clinical and the sort of epidemiological. There's a bit of backplay between both, but essentially what we're talking about is this statement here: activities such as lifting weights, using resistance bands and barbells. And what happens if you do this regularly? It enhances skeletal muscle strength, power, mass, and this has all sorts of different health outcomes.
Sorry, Jason, you're not in presentation mode. We can't actually see you clicking the slides.
Oh, can you see the slide transition?
No, that's why I thought I'd stop you.
Okay.
If you click on the presentation. Sorry, everybody.
So
I just wanted to see the slide. Yeah, no. If you click on, yeah.
That's it?
Not yet.
You can't see the slides transitioning?
No, we can't.
Okay.
That's all right. This is what Zoom and webinars are all about.
Okay, so what I'm going to do is going to run it straight off my laptop.
That's all right. But this is what Zoom is all about. It happens. There we go. Perfect.
Okay, so I was just talking about the muscle strengthening being part of the physical activity guidelines, and I do most of my research around there. And then I was talking about how it's not really well defined in the literature, so I'm just skipping over what I've done previously. But basically, you can do muscle strengthening exercise for a whole bunch of reasons. Particularly as a public health scientist, I'm most interested in its applications to general fitness and health. So this, I mean, people engage in muscle strengthening exercise for a whole bunch of different reasons. And as I said, the predominant one is general fitness and health. So from a clinical perspective, and this is just a really brief slide, and this field is very complex, but what I've just done is summarized the effects which muscle strengthening exercise has in a clinical setting. And we think about the most common ones are musculoskeletal and functional. Musculoskeletal can mean things such as increasing muscle mass or reducing the prevalence of sarcopenia or dynapenia and bone density. But now there is enough evidence at the meta-analytical level, so sort of pooling together all clinical studies to show it improves glucose metabolism, insulin sensitivity and hypertension, and also adiposity. It also has favorable effects on cognitive function and anxiety and depression. And all these references are provided in my article, which I'll show at the end of the presentation. But what's really interesting for me as an epidemiologist, this is now being shown in prospective cohort studies. So this means the limitation with clinical studies is they bring people in for an exercise program for 6 to 12 weeks and then find out what's happening at a molecular level or whatever the outcome may be. But these prospective cohort studies is they have a measure of muscle strengthening exercise at the start of the study, and they follow them up over a period, and it can be up to 20 years, 8 to 10 years. And there was a meta-analysis last year by Serafad et al. That showed, compared to no exercise, muscle strengthening exercise, had a hazard ratio reduction of 23%. And it's also important to note that it's now associated with sort of large public health problems. So there's incidence of diabetes, metabolic syndrome, and incidence of cancer and cardiovascular disease. It's also an interesting study out of America to show that muscle strengthening exercise was associated in a large population sample of men with reduced gains in waist circumference. So it's really exciting for me. These are very early days in the field, and this is why I've sort of tweaked my interest. Okay, so for physical activity epidemiology, it's predominantly focused on aerobic exercise, and more recently they've been focusing on reducing sedentary time, and there's comparatively little studies done on muscle strengthening exercise, the prevalence, correlates, and outcomes. So about 5 years ago I started really getting into this research field, and the next couple of slides I'm going to be talking about the research field in general. So I use what's called a behavioral epidemiology framework, and this can be applied, it's typically applied to any sort of behavior, such as smoking, alcohol consumption, physical activity, etc. But it occurs in 5 phases. So essentially we're establishing the links between the behavior and health, how to measure it, the influences, design interventions, and translate research to practice. My research, and I've adapted this as the muscle strengthening exercise epidemiology framework, and I do my research basically in these first 3 phases and looking to get into the other phases. But the field, I mean, this reflects its maturity. The sort of the translation and the interventions are yet to come at the population level. So I'm forming some formative work, hopefully, to build into those phases. But today I'll be mainly talking around the 3. Okay, so in 2016, I published a paper called Pumping Iron in Australia, and this was the first ever paper looking at the prevalence trends and correlates of muscle strengthening exercise. And what I did in this paper, I pulled together a sample of almost 200,000 Australians. And I'll just briefly talk through the way I analysed the data. So I used a large population survey, which it's called the ERAS survey. It's the Exercise and Recreation Survey. So for 10 years, they contacted people, I think it was 4 times a year, quarterly, and asked them what type of activities they did for exercise and recreation. And what I did with this study was I pulled all together the activities that are theoretically associated with muscle strengthening exercise, and you can see them down the bottom. So I pulled all these together, and then I just simply looked at those doing none, those doing insufficient, and sufficient. And what we saw was a whopping over 85% of people did no strength training in that period, and very small proportion did insufficient, and only about 10% of Australians were meeting the physical activity guidelines or the muscle strengthening exercise guidelines. So this was a little bit of a surprise to us. It's the first time it had been quantified at the population level. So more recently, I'm just going to show you a study that I got published last week, and I expanded this work to conduct a study looking at a 24 country comparison using a large European health survey. And what I looked at was how many people were meeting the guidelines. And at Europe, it's about 17.3%. But what we saw in this study was an interesting pattern where the countries in North and Northwestern Europe had the highest prevalence levels, whereas countries down in the southern and eastern part of Europe had very low levels. And for some of these countries, it was less than 5%. Now, Australia probably ranked in the bottom 3rd if we were to use that study. So this is the first multi-country study. There's been literally dozens of multi-country studies on aerobic exercise and sitting time, but this data is the first multi-country study. So then what about trends? So I analysed a large data set from America, and I looked at trends in muscle strengthening exercise guideline adherence between 2011 and 2017. And what we showed was that it was basically flat. There was I guess you could argue a moderate increase, or what's that, 1.1%, 1.2%, which is not really a lot. And these are big samples. So if you can see down the bottom, the N equals, almost, I think it was N equals 420,000 people. So it's a huge study. Interestingly enough, when I looked at the data in a little bit more depth, so this is looking at sessions per week. 0 is the dark bars, and as we get lighter, that that's more, so 4 or more times a week. We saw that there was a decline in people doing 0 sessions, but the actual real incline or the decrease was in those doing 4 or more. And we had to hypothesize in the paper that it's probably due to fitness crazes such as CrossFit, F45, so people doing really high amounts of resistance training, and it's probably not a great public health initiative to get people to do those type of things. Okay, in this particular study, I was curious to look at how many people were doing no muscle strengthening exercise versus no aerobic exercise, and it's almost double the amount of the population do no strength training. So I argue that it's twice a bigger problem as a lack of aerobic exercise, but I'm yet to get too much traction with that argument. And we look at how many people actually adhere to the guidelines, and around about 50% adhere. And this is a large sample from America of almost 1.7 million people, and only 30% of people adhere to the strength training guidelines in that particular study. Okay, so what I'm going to do is just really skip over some of the correlates. So we showed that muscle strengthening exercise declines with age. So this is the odds of meeting the guidelines. So the reference group is the youngest, and there's a drastic decline as we get older. There's also one by education. So the more educated people were more likely to meet the guidelines, and also one for, in Australian context, people in metropolitan or people in remote regions were less likely to meet the guidelines. I'm just going to skip over some of this in the interest of time. I did a large study on muscle strengthening exercise and obesity, and I looked at 4 different groups, meeting neither, MSE only, MVP only, and meeting both. And what we showed was that across obesity classes, that meeting both was the most favorable, but when comparing meeting MSE only and MVPA, there wasn't much difference for obesity, but in the higher classes, there was a little bit of difference. I'll skip over that. And this was a study which I did on depression, and it looked at the joint dissociation. So to your left, I haven't got a pointer, but these are the least active populations, and to your right are the most active. So we compared to the least active, and what we showed was there was a dose-dependent association. So basically this slide is looking at the joint associations with muscle strengthening exercise. And what we saw was the addition of muscle strengthening exercise lowered the prevalence relative to those who are doing none. So a little bit of muscle strengthening exercise decreased the prevalence of depression. Okay, so take-home messages are 70 to 90% of don't do enough muscle strengthening exercise. The addition of muscle strengthening exercise is likely to be important for health. I think for future public health strategies, we should be getting populations from doing none to some. Everyone, we should be targeting everyone, in particular older adults and from those from lower income levels. Limitations are, this is self-report instruments. There's no way of objectively measuring muscle strengthening exercise. We only have an idea of duration, frequency, not on duration intensity. And this is cross-sectional data, which we know little about the causal associations. But by way of strengths, it's a large representative sample using standardized and validated instruments. Okay, so I'm just going to spend 2 slides talking about how we can fix this problem. I think the key areas are using affordable and attractive or utilizing places where people can do it, access to professionals who have skills and knowledge, equipment or home-based activity, and using mass media campaigns to target and really try and debunk some of the negative stereotypes. And I'll just skip over this last slide in the time of interest, but most of this data is presented in my recent paper, and this is an open access paper. So if you can, I think Tuya will provide this for people, but this goes into a little bit more depth and provides references. Thank you for your attention.
Thank you so much, Jason. I think it is a very important talk at the moment, considering what we're doing with COVID. Leads me to a question straight away, because you mentioned that you talked a lot about the behavior and then the sedentary time, and considering now that many people have been at home for 8 months. So again, in Melbourne, we just come out of lockdown. So how do you think this is all going to be impacted, considering with depression and the sedentary time? Because I'm quite confident that that sarcopenia is going to be quite a lot. Now when we sort of get over the acute into looking at the general population, I think there's going to be an issue with chronic diseases, depression, and sarcopenia. What is your advice? What should we do now? How can we get back on track? And what is the importance of strength training in all of us to get back on track?
Okay, so I guess in getting some feedback there. Can you hear me okay?
Yes.
Yeah. Okay, so I guess in relation to COVID, and one of the things we were caught by surprise is how people couldn't leave their homes. So it may be a alternative where people can't leave their homes. As far as COVID affecting sarcopenia, and it'll affect inactivity, which will affect sarcopenia. So I think that's a point. But I think what COVID has really taught, well, not taught us, but showed us that we need to be adaptable with our physical activity programs. And for people who are limited in their activity levels, strength training may be an alternative. And how you integrate that into the home environment, maybe looking at new technologies, virtual trainers, and all those particular things, I think are important.
Yeah, because I really think it's going to come up, really, the sarcopenia and the long-term effects in the future. And I will definitely be sharing all your papers because I think it's a key thing for us. We need to understand really the long-term impacts, and we've been really looking at the acute cases at the moment, but it's more the inactivity and impacts of that to the general population. I think that's going to come out next, and we need to be focusing a lot on that. As a general rule, from your viewpoint, how important overall is strength training for our health?
Yeah, I mean, I won't go on record, and this is going on YouTube. I won't say it's as important as aerobic exercise. I still think aerobic exercise is very important for cardiovascular and cardiorespiratory health. But I think, it needs to be, and I think I tried to make the point, is that twice the amount of people don't do any than aerobic exercise. So there's a huge potential to integrate it more into people's lives. How important is it? I think it's extremely important, but we need more studies to look at the long-term effects of it in population cohort studies. I think the clinical evidence is extremely strong. There's no debating that, but the difficulty is going to be in how to integrate it into people's lives. And that's really the most difficult component. Yeah. And probably the other thing I'll emphasize is that if you're currently doing none, even a little bit is likely to have population health benefits. So we know from aerobic exercise that the biggest population bang for your buck is from getting people to increase in doing nothing to doing something. So we don't need to be getting into this whole bodybuilding or fitness craze or celebrity workouts. That's not going to work. It's going to actually turn people away, and I think we need to be more moderated in our approach to promoting it.
Yeah, hopefully we can do that. Thank you so much, Jason. It's a fascinating topic and I could listen to you forever, but we better move on. Thank you again, and I'm happy to present our next speaker. Our next speaker comes all the way from New Zealand. So Allan Zhang is from the Selwyn Foundation in New Zealand, and he's a registered clinical exercise physiologist. And following his clinical training at the University of Auckland, he gained experience working in private practice and at the AUT University over a period of 2 years. Allan joined the Selwyn Foundation in October 2019, and during his time at Selwyn, he's provided functional and balance exercise assessments and also comprehensive exercise programming and using HUR. So he will give some insights on how you can get the best out of using HUR and get the reports as well. In addition to performing day-to-day clinical duties, Allan is also responsible for providing education seminars to medical specialists on the importance of structured exercise and healthy aging. So welcome all the way from New Zealand. Welcome, Allan, and the stage is yours.
Awesome. So to start with, I just want to thank everyone for joining us on the webinar and HUR Australia for organising this big event. I also want to thank Turi for inviting me along to present at the seminar. So I'm quite excited to share some of our experience with using the HUR exercise equipment, as well as our experience in the day-to-day service delivery. So before we get get into the case studies, I just want to give everyone a little bit of background on the Strength and Wellness Clinic at the Selwyn Foundation. So we started back in March 2019 at Selwyn Retirement Village. Since then, we've expanded our size into 3 different clinics in 3 different locations in Auckland. So currently, we've got about 400 enrolled clients. So the majority of them are from the Selwyn retirement villages, and the rest are from the local community. So the average age of our clients is 78 years old, with the youngest being 56 and the oldest being 95. So the majority of the clients, and they come do the exercises twice a week, which is slightly less than the ACCM guidelines. But we've been finding it actually, it's more practical and it's more feasible in this population cohort. Cool. So just a little bit of sharing a little bit of experience with our experience in using the HUR exercise equipment. So the biggest feedback we've got is actually how easy the entire system is to use from a client's perspective. And from a hardware perspective, I guess there are very, very few moving parts on the machinery, which means we're really trying to minimize that injury, the risk of injury, as well as misuse. So the best feature from our perspective is actually the software. It tracks how each person's been performing from session to session, which means every 10 weeks or so, we can have a little sit down and discuss our progress and work out where to from there. So another key feature of the HUR machinery is actually its ability to have small load increments, which is really helpful for rehabilitation purposes. So going to the case studies, the 2 cases that we've picked actually represent both ends of the elderly care spectrum. So the first one, the first person is apparently healthy with basically no comorbidities. As such, the treatment goal is really just to improve that overall function and preventing any future issues. And the second case is slightly more complex. So this is a patient living with multiple sclerosis, and therefore our goal is really just to maintain that functionality for as long as we can. So a little bit of background information on the first case. This is a 72-year-old female living with hypertension, which is controlled via medication. And she's also got a history of recurrent ear infections, which has somewhat affected her balance. So prior to each patient starting an exercise program, we run them through 2 functional assessments. So the first one being a 5-time sit to stand, and the second one being a timed up and go. So we sort of use those 2 tests just to get a baseline measure of how functional someone really is. And we'll also use those 2 tests to look at if there's any obvious movement deficits. So another piece of HUR machinery that we use is the balance platform. So it puts the patient through 4 different scenarios, all of which challenge the proprioception, visual, and vestibular balance system. At the end of the tests, it provides a little scoring system. So that makes the results really, really easy to visualize. So going to this case, her functional assessment results are actually looking really good. Everything is within her age and gender match norms. And looking at the balance side of things, so the biggest thing for this person that stands out is probably the high visual dependency, which means she really, really relies on that visual input to maintain that balance. So it could potentially put her at risk of falling when her vision is not fixated on where she wants to go. So take into account her assessment results as well as, not sure what happened there. Take into account her assessment results as well as her personal goals. We've come up with 2 different objectives for the program. The first one really is just to improve her physical function through improving overall muscular strength as well as power. And the second goal is to prevent any falls by reducing that visual dependency. So moving on to the exercise prescription and the progress that we've made over the last 22 weeks. So for the weight training part, we've decided to focus on large muscle groups that are responsible for carrying out activities of daily living. So things like your chest press, cable pull, leg press, trunk flexion, and trunk extension. So in terms of the repetition range, we've decided to use, because our goal is really just to develop that power and strength. So we've decided to go with a 5 to 8 repetition range, especially for the lower extremities. So for the balance side of things, our goal is to focus on that proprioception. So everything was done with eyes shut. So over the span of 20 weeks, we've managed to progress her chest press by 43% and her trunk flexion by 28% and her lower limb exercises by 25%. So that's excluding the 2 massive lockdowns we've had in New Zealand. So on this page, we're really just picking on one particular exercise, which is the leg press. The leg press is quite interesting because we've been finding it very, very indicative of someone's overall function, especially in this population cohort we work with. In this particular case, over the span of 20 weeks, we've managed to improve her leg press 1 repetition max by 29 kilos. So going from 60 kilos up to 89 kilos. So this page also actually highlights a point I made earlier about the software's ability to track how each individual has been performing. So to look at if our exercise interventions actually worked, we'd do a reassessment every 10 weeks. So the results on this page, it's actually from the latest reassessment. So for the 5 times sit to stand, we've managed to improve that performance by 132%, going from 12.3 seconds down to 5.3 seconds. So for the timed up and go, we've managed to improve that by 72%, going from 8.1 seconds down to 4.7 seconds. So in terms of the changes in the balance side of things, the top graph is from our initial assessment and the bottom graph is from our most recent reassessment. So the biggest change in the balance side of things, it's actually the visual dependency, which means through the use of resistance exercises and balance exercises, we're able to make her less visually dependent and therefore making her at a lower, so shifting that from low risk category, that medium risk category down to a lower risk category. So going on to the second case, this is slightly more complex. So this is a 64-year-old male from the local community, and his primary diagnosis is progressive MS. And associated with that is a global muscular weakness with his left leg slightly stronger than the right leg. And he's also got an issue of chronic fatigue. And with that, he's also got a loss of coordination. So all of those factors combined above means the patient requires a lower walking frame to mobilize. So looking at this patient's assessment results, for the first test, it took us 11.6 seconds to complete 5 times sit to stand. So all of the tests were done with his hands pushing out from the armrest. So for the timed up and go, we've managed to complete the maneuver in 20.5 seconds without his lower walking frame. So looking at the balance side of things, there's actually a little bit of similarity between the first case and the second case. The only thing that really stands out is the high visual dependency. So again, he's really relying on that visual input to keep him upright. So based on the discussion that we had after our initial assessment, we've come up with 3 primary objectives for his program. The first one is to prevent any falls. And the second one really is just to maintain that physical functioning and slow the disease progression rate. And last one is really focusing on that cardiorespiratory fitness for the reduction of cardiovascular disease risk. So looking at the exercise prescription for this patient, the basic recipe between the two cases are very, very similar. So twice a week, functional-based resistance exercise combined with a little bit of aerobic and balance training. So in this particular case, the biggest challenge that we faced is his balance, his inability to control his balance during pivot transfer. So this is primarily because he's got a limited neuromuscular control and also due to his one-sided weakness in this leg, in the lower limbs. And the solution that we've come up for this is to perform single-sided resistance exercises and really focusing on that eccentric phase for the weaker side. And another factor that we had to take into account is the factor of fatigue. So to deal with this, we've decided to increase the rest between each set. So going from 60 seconds up to 300 seconds. So the second thing that we decided that we might have a little bit of issue with is his fluctuation in energy levels from day to day. So we've decided to go with a rating of perceived exertion-based intensity prescription.
5 minutes.
So the last thing I want to highlight on this page is really on the exercise progression rate. So because his medical history, we have to be really, really careful with his progression rate to avoid any exacerbation of the symptoms. So this is where the HUR machinery's ability to have small load increments has really helped. So looking at the overall progress we've made over the last 24 weeks, for the upper body exercise, for the chest press, we've managed to improve that by 81%. And for the trunk extension, we've managed to progress that by 28%. And for the lower extremity exercises, we've managed to improve that by 49%. So looking at the reassessment results, we've kept all experimental conditions exactly the same from the first initial assessment. So for the 5 times sit to stand, we've managed to improve his performance by 27%. And for the timed up and go, we've managed to improve that by 13%. So in terms of the progress that we've made with the balance side of things, so the highlight from the 2 assessments really, again, is that change in visual dependency. So going from a medium force risk down to a low risk category. And what's even more important is that since the patient started our little exercise program, he has not had a single fall so far, which is really good to see. Any questions?
Thank you so much for a very fascinating talk. I like the fact that, especially that you use the balance platform. I think one thing that's interesting with both the cases, because often a topic that comes up is the correlation between strength and balancing and functional ability. And in both your cases, the function was increased, and in the other one was almost even more. In the first case, the function levels were high, went really high up. What do you think is the key? Like, how is, the importance of strength and balance and the function? How important do you think it is?
How important is resistance exercise?
To improving function, like how could you explain the correlation in them? Because that's often something that people think that strength training is not worthy because it's not functional. However, with your testing, you have verified that the functional ability increased in both the tests with the strength and balance ability. So I'm sort of wondering, what do you think is the best combination or the best cookbook case for a client to improve the function?
Yeah, that's a very interesting question because the population cohort that we work with, it's the majority of the people that we work with is 70 years or older. So that decline in functional capacity has really become a massive issue. So in terms of the resistance exercise side of things, the key focus really is to make their day-to-day activities a bit easier. So being able to stand up from the chair, and it doesn't take 10 seconds for them to do 5 of them. That's really, really important. So essentially what we're doing with our exercises program is that performing those functional tasks, but with a little bit of weight added onto their existing body weight. So if we can make our patients really, really good at performing those weighted functional tasks, when they walk out of the gym and they start doing things around the house and or playing with the grandkids, everything just seems so much easier.
That's a really good answer, and I think it's good advice, because it's a topic that often comes up, and I think the whole point is to relate everything that we exercise to real life and really try to link the training and the function, and then also our ADLs and how we can work through. The other, interesting I had with both the cases, you talked about the vision. And I think you mentioned in the talk that you do some exercises with eyes closed, if I remember right. And what do you think are the keys in targeting the vision dependency? Because I think that's one of the big things, especially in older people, when you walk in traffic, when you have noises and traffic lights and people passing you and skateboarders and bicycles, what do you think is the most important thing in trying to losing the vision dependency?
So even for young people, the visual dependency is probably accounts for 70% of your ability to maintain that balance, whether you're walking or you're standing. But in the older population, what's changing is that the person's ability to quickly correct that action of falling over to one side. So for someone that's 30 or 40 years old, when they've fallen to one side, they're able to quickly step out and catch themselves. Whereas for the older population, when their muscular strength start to decline, they still go through the same process, but what's different is that ability to quickly catch themselves.
That's exactly it. So actually, that leads me to another question. Are you doing any exercises for reaction time, considering what you were doing? Do you do any stepping exercises, or are you playing the games where you step? Are you particularly training reaction time?
So one of the exercises that we're currently doing, it's actually with a tennis ball. So the person's going to be standing either on one foot or in tandem stance. So I'll be the person passing the ball to them, and basically their job is to maintain that balance and catch the ball from different directions. So really challenging that reaction time as well as that ability to multitask.
I think it's fantastic, and I think the cognition, especially with MS, so we have these neurological diseases where the cognition is a key part. So I'm combining that, and I think it's nice that you bring the athletic training, because that's what the footballers are doing, bringing that to the older population. So I'm sure they feel like superstars and athletic stars. So I think it's fantastic. Now, thank you so much, Allan. I think it's always great to get a clinical input, and thank you for the practical tips as well. I'm sure we might have to talk again. To see what you are. I think it's really good to get the little tips people to share them with everybody else. So thank you so much for the data and for everything else you've given to us. All right, thank you, Allan, and we're going to move to our next speaker. So our next speaker is Nathan Hall, who's the Health and Wellbeing Manager at the BaptistCare New South Wales and ACT at home. Nathan is the Health and Wellbeing Manager at BaptistCare at home. He is an experienced exercise physiologist with experience in service and operations management, skilled at strategic leadership, and also coaching the leading through others and operation management in aged care, fitness, and also the allied health industry. He has a passion and commitment to developing accessible physical activity models to all. And also Nathan really wants to enhance the health and well-being of the community that he serves. And in his current role, he can fulfill his passion by leading a team and creating programs for health and well-being. So welcome, Nathan. You have the next 15 minutes.
Thanks, Torre. So yes, my presentation is really about how the allied health team at home actually work together with the at-home staff to understand what's happening with our clients as they age and as they become socially isolated at home, and the reduction of movement. So what I'm going to talk through today is just a little bit of context information around BaptistCare at Home and our well living framework. The COVID impact, which some of it relates a little bit to what Jason was presenting earlier on, which was great to actually see. Some of the supporting evidence that I found from a report from the UK. And then what we actually developed in terms of the Online Active and Strong program, and then a Where to From Here piece. So in terms of that context, BaptistCare at Home is committed to supporting over 9,000 older adults to remain independent and safe in their homes. We are a for-purpose provider, and there's 11 sites across New South Wales ACT, and we primarily work with home care packages, the Commonwealth Home Support Program, and do some private services as well. In terms of the well living approach, it's a strategy that represents the commitment by BaptistCare to develop a holistic wellness model that is underpinned by the belief that older adults can improve their health, functional ability, and quality of life as they age. So what we actually did is looked at those domains of health, and we come up with our pillars of be well, think well, and connect well. So the impact of COVID commenced really. So in May and June this year, some of our physios were out seeing clients in their home, and they noticed the impact of the reduced movement in the clients' homes. And there was an anecdotal shift around that in terms of what they were reporting. This triggered us to actually go to our site managers and also our care facilitators, which was like our case managers of the home care packages, and discuss what is actually happening out there, and look through some of the physiological changes and the impact of that to our client base. So yes, we started off with the reduction of movement, and as previously presented, there is that loss of muscle strength that occurs with that. There is that increased risk of fatigue, feeling a lot tired when they're actually aren't actually participating and actually doing any more work than they were previously. And then there was a difficulty in actually walking as well. So there's a change in that mobility status, which has occurred. And for me, this was when it really come in to start to present to our care staff around the risk of chronic disease in two ways. So the risk of their current chronic disease and what they're actually dealing with at the moment, such as like if they're managing their pulmonary condition with exercise in terms of their O2 efficiencies within the muscle, or a decrease in the risk of joint pain and things like that, or using exercise to help improve their coordination and balance. But I guess secondary, there is that risk that they could start developing extra or additional comorbidities or chronic diseases within that. So like developing into increased risks of frailty with the blood changes and metabolic disease and things like that. So the message that we wanted to get across to our staff was around that remaining active is vital, and really to try and encourage that allied health interventions wherever possible. And whilst these can be a little bit more of a technical way, we actually started to get them to think about questions as well. So that might be a little bit more operationally based for them to think about their client. So has the client needed more personal care support? So when COVID struck, a lot of clients actually decided to reduce services or cease services because of the risk of COVID. And then when they actually started to commence the services back up again, have their actual personal care needs changed and increased from that, the reduction of movement. Next one, is the client having more difficulty walking than usual? As another type of question. Has the client had a change in any medication? And that sort of talks to some of that blood profiling changes that Jason might have actually previously mentioned. And then has the client actually stopped any of their social engagements? And with those social engagement, the client was still maintaining a level of mobility and independence, walking outside the home, and there is that incidental use of exercise when the client is doing that. So with that information, last month, I actually came across this study, or this report that come from the Age UK, where they actually surveyed 1,800 clients over the age of 60 in August and September. And some of the interesting information around that is presented here, but it sort of supported that presentation that we did to our care staff and support facilitators around there's a 40% reduction of people that can walk as far, 40% unable to walk as far as possible, and the pandemic restrictions and the shielding. So the UK called the reduction, or the clients, when they told their older adults to stay at home and not go out, they called that the shielding effect. And there was a reduced access to usual healthcare and coping mechanisms. So people accessing those physical exercise classes and support groups wasn't there, and then that was actually led to further chronic disease impact. So as well as that education piece that we provided to our staff, it was also then thinking about, well, how can we be creative? And a lot of people had to develop these online programs, and I guess this is an example of how BaptistCare tested the waters for the clients that already have technology and delivered a program at home. So that's me in my home environment doing some exercises with clients. So it was a real big shift for BaptistCare at the time to commence this for both clients and also for the staff themselves. And there's a lot of questions around the platform and the use of how online tools and how clients would engage with that if we haven't previously done that in the past. And then for me, as an exercise physiologist, well, how do I actually do that risk assessment piece if I'm not going to have that individual contact with clients and understand their ability in terms of their functional ability or their balance? So the online Active and Strong program was created, and there was two type programs that I instigated. There was the morning Kickstarter, which was really a standing strength-based exercise and stepping. And then there was the Standing Strong program, which was in the afternoon, so really focused on the strength and balance exercises. I sort of added an education component to that as well, and I also took one of the sessions to the kitchen and started showing people how you can do those kettle exercises. So, when they're boiling the kettle, what type of functional exercises can you be doing while the kettle's boiling at the kitchen bench in a safe environment? So the registration process itself, I had 140 people registered, which surprised me a lot. The average age was 80 years of age, and that also surprised me as well. The minimum age was 42, and that was because we had actually a staff member interested in doing the program themselves as well. And the maximum age was 100 years old, a client that was 100 years old. I collected some demographic details within it and then medical information. And as you can see on that slide there, the graph there beside it, and really it was to try and start to give me a picture of what type of conditions that the clients were actually dealing with and comorbidity. So I also looked at the lifestyle interventions of what clients were doing in terms of smoking, weight loss and gain, but also a quick question around, do they participate in regular exercise? And I could have been a lot more specific with this in terms of the guidelines and strength training potentially, if I was to look back on it. But it still gives a clear indication that half of the people that were living at home within this response rate were not participating in regular exercise at all. And then we also looked at client goals, what they were hoping to achieve. And a lot of it was based around independence, maintain my mobility, increase my strength at home. So that expression of interest or risk was my actual risk assessment form. And the intent of that was really to sort of decide on, to help me develop an eligibility criteria for the people that come through. And I really looked at a confidence questionnaires, some confidence questionnaires and a capability questionnaire. And there is a difference between the two. And because a client can be well capable to do a task, but they might not actually have the confidence to do it. And that's what I find exercise and participating in regular exercise allows people to increase their confidence to actually participate in exercise strength training. So looking at some of the questions on a scale between 1 and 5, 1 being not confident and 5 being very confident, how confident can they stand up without using the chair? And there was a high response rate there that people were quite confident to do that. But then this became a little bit of a leveler for me and started to confuse me in terms of my eligibility criteria around how confident are they to actually balance on one leg. And that sort of spread everyone out a little bit more as well with that. And then finally, within that confidence scale, I actually asked them around how confident they are able to walk without a walking aid. And there was a high response rate for the clients to be able to do that. But interestingly, though, there is a large number that do use a walking aid when we look at this type of skill and in the capability side of things. We also then sort of looked at the daily living, and the intent of this type of question around personal care was the idea that if someone has a higher levels of personal care, they're a higher need type client, and they might need more intervention and allied health interventions into that client's there. And the response rate for here was like they need minimal help with their daily activities such as housework. And for me, that sort of suggested most of the client base that were registering in this may have been a CHSP or a Commonwealth Home Support client where they are an entry-level based service. But it would have been nice to actually have that clearly defined in my questionnaire, which I didn't do as a reflection.
5 minutes left.
Okay, so in reality, what actually happened, I actually had to modify the classes, and I didn't actually define the sets and reps within it when I was doing those exercises. I sort of used more of a time-based scenario with the strengthening exercise I did, and gave the clients the options to participate at their own intensity. So how fast they wanted to do it, they could keep up with me, they could work slower, or they could work quicker, which sort of allowed me to open up the exercise class to a wider group of people. I had to have a clearly defined introduction piece that really spoke to the setup of the room and making sure the chairs that they were using were stable, had arms if they needed to, if they were using a walking aid that it was locked in front of them, or having a secondary chair in front of them as support. The shoes, making sure they're not actually wearing slippers at home and doing the exercise. And then also then the floor, making sure it's a nice flat floor, non-slip surface, no mats or something to trip over. And then some basic education around an RPE, so the rate of perceived exertion, how intense the exercises should be, and if they started to feel any difficulty with that, just to slow down and stop and rejoin when they feel comfortable with the next exercise. So with the lessons learnt, participants were really keen to join online. And the online registration process did quite well with the utilising of Google Forms and things like that to do these type of questionnaires and the analytics. However, I did have poor live attendance, but I am inspired by that there is clients that did participate with it. And what I did as a measure of that is I also, using the platform that I did, I could record the sessions and then I could upload them into like a YouTube video, and I sent them out to all the clients that registered to attend. And I still have clients now participating in the programs and sending me emails saying, thank you, I participated in this class. And I found this well, but I did this one difficult. So although that's still interesting and inspiring to see. I used MS Teams as a platform, and that wasn't the best platform to use. If you didn't have an MS Microsoft account, it provided extra challenges in terms of needing to get to an anonymous sign-in process, which provided too many clicks to get there for a novice user. And then also the device, what type of device they were using, tablet, personal computer, phone. I wasn't able to provide all that support for that, and the way that you access each of those webinar sessions was a little bit different on those devices. And overall, the positive feedback, at the end of each session, they had a link to provide some feedback on each session, and overall the feedback was very positive in terms of the length of the session, how they enjoyed it, and what the benefits they were getting. So where to next for me? There's still a large enabling piece that we need to do for staff and for clients in BaptistCare. And the first piece of that is looking at an online social club. So engaging in that, and that we can start to use that as a leveraging piece to start doing more virtual type services. So things like your allied health interventions, where you're seeing people in rural and isolated areas. If I was also to do it again, would I actually do a virtual one-on-one assessment with some of these clients? I probably would, but that may have actually started to include a cost for me. And at this point in time, I was really just testing to see how our clients would engage. So that would be something that I would look at in the future. And then looking at the role of the health and well living, a comprehensive assessment, and how that can assess our care staff and our care facilitators, and really integrating how those outcome measures are actually seen in our client management system. Because a lot of times when the assessments go in from the physio or the EP, it sits in there as a sheet, not as a document that you can actually pull out and do some analysis on site, demographic, location. That's the reference there to that the UK report that come through. But then I'm happy for any questions.
Thank you, Nathan. Very fascinating, and I like the details. Mm-hmm. I think my first question for you is, obviously during COVID, I mean, Sydney has had the similar impact in Melbourne, not quite as bad, but what do you think is the main impact you've seen in your clients at home? Is it the depression, or is it this isolation related, or is it inactivity? And what are the main problems you faced during COVID, and how do you think we can tackle them and return to normality?
Yeah. Well, I guess I spoke through some of that in the presentation, where there was a large number of clients that ceased services or reduced services. And whilst that is, I guess, manageable at a time for the client, a client actually has the CHSP or a home care package for a reason. So that's not a sustainable way to actually reduce the services or go without. So that's now rebounded quite quickly though, really now. But that was probably one of the biggest challenges initially. So then looking at programs like this, the virtual piece, to try and get it into their hands to actually enhance their quality of life still at home while they are isolated and self-isolating or shielding was probably one of the big challenges. Yes.
Did you have many clients who can't use, they don't know how to use laptops or can't go online? And is there anything you could offer to all those who couldn't access the services?
Well, yeah, that's the challenge, and one of those enabling questions that I'll put as the next step, really, because the clients there's a number of different type of clients out there. Ones that are actively using the technology now as well. Ones that actually want to be engaged and learn, and then the others that probably don't actually really understand it and don't want to be involved with it. So it's about going through that piece with all our clients and understanding where they're at, and then offering those type of solutions for them. And I think a large number are, and there's different programs out there that can help that. And we did have an innovative growth funding where we were concurrently actually putting in 300 Breezy tablets into our CHSP clients' homes over this COVID period. And then Breezy is a platform that sort of personalises the tablet. And it's a platform that sits on top of a Samsung tablet, and it makes it personalised to the client. And then you can actually make it with larger tiles on it, and you can actually probably start pushing a lot of notifications and emails and all that great stuff through there. So that's something that they're looking at, and there's a number of those type of providers and services out there. So that's really an enabling piece that we are looking at.
What do you think? What about from here on? Now next year is going to be a recovery from COVID year. Fingers crossed, the 0 cases. Do you think the home care programs are going to change? So with regard to sarcopenia and frailty and falls prevention, do you think the home services could change? Or could we, for example, use, if we get home care nurses, could we use them, teach them some allied health skills? Do they have time to do that? Do you think there's anything how the home care could change next year when we recover from COVID to try to return back to normality?
Well, yeah, definitely. And even after the Royal Commission within Australia, within aged care, what does that mean, and what the outcomes from that mean for that? Is there more package levels? Is there more packages themselves? So there's a large number of questions that could be occurring within that. And the questions around the reablement piece within that, how does that fit in there? How do clients engage with that piece and understand that as well? They're all big questions to be answered.
I think a combination of Royal Commission and COVID really gave us a great opportunity to create something wonderful and make 2021 the new 2020. So hopefully it will come a perfect year when we can start to treat our older people and try to treat everyone better. And actually, hopefully we've learned our lessons and we'll can live happily ever after. It's like a story tale. Thank you so much, Nathan. That was absolutely fantastic. And now it's time for me to start, welcoming our last presenter. I'm just going to go over the slides. So our last, sorry, I'm trying to get the slides up. Our last presenter is Daley, who is the CEO of Integrated Living. An Australia-wide organisation delivering better health outcomes by offering a wide range of aged care and disability support. Catherine has overseen the growth of the integrated living to its current position as a significant rural, regional and remote-focused entity, providing health management and wellbeing services to older Australians using entrepreneurial activities such as e-health and the use of assistive technologies, innovative models of service delivery, new business models, and targeted amalgamations. So Catherine is one of the people who can definitely give us a very, very nice understanding of how we can make things work for the wellness for everyone Australia-wide. Welcome, Catherine.
Thanks very much, Ture, and thanks for having me today. My presentation is probably a little bit different to what the other presentations have been, and certainly, I provide the same evidence that Allan's provided and Nathan, and reiterate many of the points that Jason's made. We have seen incredible advantages and improvements in health and strength for our clients across Australia. But today I'm really looking at a bigger picture. I'm really talking about the management of health and wellbeing across Australia, and specifically in those rural and regional areas. So a little brief overview of integrated living, a little bit about our journey, the importance of aligning the needs of rural, regional and remote older people. And I noticed, Jason, you referred very much to some of that socioeconomic and chronic health conditions in your presentation as well. A little bit about how to manage a transformation, and then obviously looking a little bit at our COVID response as well. Thanks, Troy. So just looking here at the overview, you can see that we operate across quite a vast geographic area, but only in the rural, regional and remote areas. So we don't operate in the metro areas of Brisbane, Sydney, Melbourne and Canberra CBD. We are community-based only, so we predominantly operate in people's homes. We do have 8 wellness centres where we utilise the HUR equipment and a range of other multidisciplinary approaches to offer services to clients in a centre. And in those centres, in the last year, we had about 1,700 people attend and about 45,000 hours of service. So our clinical team is well over, probably about 120 of our staff as well. So we've built our clinical team in time. So we have 5 wellness centres in New South Wales, 2 in Queensland and 1 in Tasmania, and yet to open one we're using a virtual centre based with our Gippsland funding. So we're trialling our iHub, which I'll come to in a minute, out of Victoria. Chure, next slide, thank you. So a little bit about our journey, I guess. Really, today I just want to talk a little bit about our journey and some of the health and wellbeing we've looked at. And really since 2012, 2013, when we started our NBN, we had a $2 million NBN pilot, which we specifically trialled in rural areas with Indigenous communities. And it was very, very successful because that iterative learning style of vital health signs monitoring really suited our Aboriginal and Torres Strait Islander clients. And then we were able to successfully roll that out in 2014. We got funding for 10 or 11 regions across a couple of states. We also trialled the use of iPads from about 2013 onwards. And again, we specifically tested the use of iPads in those more rural and remote areas and spent money evaluating so that, we've got the evidence to support the benefits that were obtained through that mechanism. And then obviously we were able to roll out iPads to a great many more of our clients across various states and territories. Our wellness centres, I think we got our first HUR equipment in probably 2016 and started our first centres then. And then our Wellness for Independence programs, which are now virtual as well, group-based programs focused on those chronic health conditions from about 2017 onwards, doing virtual assessments, clinical assessments from 2018, and getting our iHub up and running certainly this year, and extending our virtual exercise programs this year as well. But our bigger goal is really around an integrated care platform, which is really addressing changes in the whole ecosystem. So partnering with PHNs, partnering with local health and hospital services, partnering with our technology partners to actually offer primary health through to tertiary health care in rural, regional and remote communities. So really looking at a holistic range of services, which is our ultimate goal. And we hope to have that platform underway early in the new year. So when we came to looking at identifying problems and looking at opportunities, which really drove all this focus on better health outcomes for more people in rural, regional and remote areas, we know that many Australians believe that health and aged care should be free. We understand the rise in chronic illness. We looked at all the reports many years ago, and we know what the chronic health conditions are in the regions where we operate, and the greater complexity because of those socioeconomic and financial areas of disadvantage, which add to the social determinants of health. Many people have that dependency on acute care facilities, institutional settings, the multiple transitions in care are very disjointed and disruptive and potentially preventative. And there's a direct correlation as you move away from the metro areas in premature death, preventable admissions and average length of stay. And we very much know that your postcode matters. So these are the areas that we're really targeting and wanting to address. There's also the poor health in the reduced quality of life. And I think, Nathan, you referred to those social connections, which are incredibly important: depression, stress, anxiety, you know, all of those quality of life indicators as well, for people to be able to contribute meaningfully within their communities. And we know that with greater choice, people do need help coordinating and looking at best options. So for us, the opportunities were around building these collaborative partnerships to affect positive system level change and deliver positive health economic benefits. So as I said, we have a very bold agenda. We know that people will need more integrated solutions, that improvements will better match the right person to the right care in the right place, that the current system's not going to work. And we know, you know, these has all come out through the Royal Commission as well. We need to establish better integrated health solutions. So our solution is a digitised integrated model that offers personalised, complete care within a sustainable business model. So essentially our vision sees us offering fully digitised and integrated community health services to tens of thousands of people, achieving health economic results that benefit individuals and communities, and ultimately the whole health ecosystem. So over the next 4 years, our focus will be to innovate, incubate, and deliver co-designed service models all along that spectrum of care, from primary health to end-of-life care. So when we look at those critical factors for business transformation, just if you wouldn't mind going back, Sheree, sorry.
I'll do my best.
Yeah.
Is that Darwin forward?
Sorry, go back one, I think. Yeah.
Is that right?
I should be at slide 5 still. Sorry, I'm still on slide 5. Yeah. You know, really looking at those, you know, critical factors, focusing on the changing customer demographics, the behaviours, the expectations, the things that other speakers have touched on today, understanding the value that people attach to the products and services and the delivery models, and then being able to quantify what the value that transforming that experience will actually bring to the person, the organisation and the system. So really looking at utilising a value creation framework so that we've got, we can assess our business cases for investment and tangible benefits. So as I said, it's very much a bold ambition and has to be done in partnership. and has that opportunity to deliver breakthrough value. The next slide, thanks, Ture. So really, when we're looking at articulating the strategy, obviously we've got to translate our passion into an executable strategy. So you can see on the slide, we have our focus for 2021. These are the areas that we're working in, but we do have our roadmap through 2024. So we developed this last year. It was a 5-year strategy. And really the strategy creates the foundations for our investment decisions. This year we're investing $5 million of our own, and obviously in partnership with a whole range of other partners. So how do we identify the resources? How do we assess our performance expectation and our governance around this? Being able to look at this significant investment, we had to have dedicated resources. So we have a transformation unit, our strategy and impact unit, with a transformation lead and a whole team of experts in system redesign, in change management, in portfolio management, project management, program management, etc. Partnerships and investment. Looking at our capabilities, and that's from the board level as well, being able to look at what your capabilities are within your organisation, within your business, and then being able to prioritise. And certainly we were able to leverage our recovery from COVID-19, for example, because we already had these strategies on our horizon, so we were just able to bring things forward. Next slide, thank you. As I said, really looking at using our portfolio management office, our governance frameworks, our investment review committee, communication, change management, working in a matrix type situation, cross-functional working teams, building the capabilities within our systems, and having dedicated programs of works to get a fully digitised and integrated health service model that's underpinned by the principles of co-creation, contestability, sustainability, and outcomes-based care. So we're looking at outcomes-based funding models as well. So in order to achieve this, we've had to build and strengthen our partnerships, grow our strategic opportunities, create new products and intellectual property, build our research and evidence base. We've just got a request for tender out at the moment around the evaluation of our evidence frameworks with a number of universities, establish our long-term value for customers and funders across the broader market, and also for stakeholders within the ecosystem. So digitisation is really the core to our new service and will overcome the systemic barriers that prevent integration and scalability. So in selecting our strategic and technology partners, our strategy has really been to use a market selection-based process and a co-creation methodology. So we've held a number of co-design workshops already with our partners so that we're building a system together, and obviously using a person-centered approach and utilising client advocates to assist us as well, and building that into the contractual relationships with our strategic partners, and obviously having a portfolio investment approach, ensuring that you're maximising your resource availability, your value creation of having a portfolio program of works linked to your long-term objectives and focusing on your objectives of your business goals. And for those that don't have a dedicated portfolio program management office, utilising project methodology and a robust disciplined approach is necessary. And, I heard Nathan saying, the learnings were, some of that approach, even creating surveys and so on. So really understanding what it is that you're trying to achieve before you set out, and then you can prioritise from that point of view. I think I'm on the next slide.
And just a few minutes left, and then we have to cut it up.
So as I said, really leveraging the strategy during COVID. So we took a very active response from late January, monitoring the situation through the early warning system, because like many others, we were already in emergency management mode with bushfires and floods. We then moved very quickly to decide our approach and design our strategic response, formulating scenarios and stress testing these hypotheses. And our response was organised around 5 work streams: workforce continuity and protection, client service continuity and stabilisation, continuity support, emerging opportunities, and financial stress testing and impact assessment. And all of these were underpinned by communication and change management. And it was very much a multidisciplinary approach. And leadership was elevated through a structured decision making, and accountabilities were clear, decisions were made at the appropriate level, and really fostering collaboration and transparency. Certainly, the direct communication with clients was important, and families, so that they were understood and were aware of what was happening. And we've seen new roles created by technology, moving to virtual delivery options. I think we had 77% of our clients transition from our wellness centres to the virtual model. We're still running 6 live online sessions a day, where people are connected virtually as well. But as soon as we reopened, people flocked back to the centres because the social connection is such an important part of the centres. But we were able to leverage the virtual allied health and clinical hubs, with clients supported by our personal health coaches. So next slide, thanks, Ture. So going forward, really we're focused on using our COVID-19 crisis to emerge stronger as an organisation and leverage and escalate the strategic plans for transformation that we already had in place, proactively creating that narrative of a compelling future and a pathway forward, and remaining focused on the long view and anticipating any new business models likely to emerge post-COVID. The many positives of collaboration, one team, cross-functional activities and so on, and really balancing that program of works, our business as usual and COVID all occurring simultaneously to prioritise, but having a recovery plan and sharing this with the organisation was important to defining our destination and helping people navigate the uncertainties. Next one, thank you. Just in summarising then, really, collaboration is important in that person-centred design, investment in capabilities, communication and engagement, understanding your resourcing, prioritising, as I said, for that long view. Agility, incredibly important in an ambiguous environment, and your staff having a flexible mindset is very important as well. And none of our strategic goal will be possible without that strategic partnership approach, and also that accountability through your project portfolio to deliver, execute and create value. So thank you very much. Hopefully I'm in time, Ture.
Thanks so much, Catherine. I have a few questions for you, but one thing that I really like that in one of the slides you have the enhancing life. And I think that's such a good thing, considering you have all the different services, that really the services we do is to enhance life. And that's something I think we all have to remember. I have one question for you, and I think it's really big because rural health is often seen that rural health, or people living in the rural areas, have a higher increase of chronic diseases. And it's more the dental care and then leads into other chronic diseases. Have you seen an impact on COVID really affecting rural areas more than other areas, or how do you see that?
Well, I think that sense of social isolation, you know, people, as I said, the premature death, the preventable admissions, the average length of stay are all higher in the rural areas. We know that as you move west, it just increases. So, you know, the isolation then overlaying that has certainly, you know, been an issue, but that's where we found that take up in those virtual programs. And I guess it's just, you know, driven our goal even harder, because we know that we can make a difference in the lives of so many people. Yeah.
Fantastic. Thank you. Now, as it's about time we come to the closure of the day, so I'll welcome all the speakers back again. And I have a question for all of you. You can, you know, say your opinions. What do you think is the biggest learning lesson of this year, and how can we address the questions and the problems next year? How can we make 2021 perfect from your viewpoint? Just take
I'm happy to go first. I'm not sure about making it perfect, but certainly, as I said, leveraging the opportunities. It's provided opportunities. Everybody's had to work differently, whether it's working remotely, you know, offering services online. We already had our integrated model, you know, our iHub, which is our virtual services, all of our personal health coaching. You know, we're already able to offer that across Australia. So, you know, it's just, I think, shown people what is possible, and, you know, the take up from, you know, some of those barriers that people perceive are there and not actually there. So I think it's been a great learning for people. You do have to focus on resilience. You do have to focus on recharging. People are fatigued. I'm not ignoring any of those things. You know, we're very much encouraging people to take time over the holiday break to recharge. But I think we've learnt what is, you know, is possible, and that those barriers are not there. And I mean, just seeing telehealth offered, you know, 10 years we've been trying to get a GP consultation online, and in 1 minute, 10 years worth of effort has happened. And if we can maintain that, that is fantastic for rural, regional and remote communities. Earlier in the year, it was, you know, if you had to be in modified Monash 5 or 6, and you had to have had a consultation in the previous 12 months, 6 and 7. You know, Alice Springs is the 6, and outside Alice Springs is the 7. People in modified Monash areas 3, anywhere over the range, need telehealth. You know, so it's just been fantastic to see that we've been able to do these things.
That's all right. Anything from Jason, Allan, or Nathan? And what are their golden keys? What are the big things for next year? No simple answers. Catherine, you do such a good job.
Catherine, really, it's about leveraging those opportunities and presenting that forward. A lot of our staff, I guess, have been stuck in their operations in their day-to-day, and it's actually allowed us to sort of step back again and go, what are the key priorities, and how can we change our service delivery to meet the needs in these types of scenarios? So yeah, I echo what Catherine just said, totally.
Anything from Jason or Allan?
I just say that you guys are at the coalface of all this work, so I think you know better the service delivery. You know, I just analyze large data sets, so I can't really offer any insights there about how. But yeah, so that's just my comment.
Anything from Allan?
The biggest, I guess, learning challenge for me from a clinician's perspective is actually realizing how many different ways we can do things, either face-to-face or through a computer. But the biggest thing for that relationship between a patient and a clinician is to, regardless of whichever way you communicate, is to keep that relationship going throughout that entire period. Yeah, so making them feel like they're supported, whether or not you are there face-to-face.
It's building trust. You're building trust and credibility. Yeah, very much everything. I think everything's based on relationships, Allan, very much so.
Yeah.
Thank you for those. And I think it's I'm going to say the famous final words for 2020 from the HUR webinar perspective. One thing I've really enjoyed, about this year is the research output that's come out. And I think the whole isolation has made us really think about isolation and inactivity. There's so many papers coming out, and there's the papers about COVID and sarcopenia. And I think that's going to be one of the key focuses next year, because I think this year, look, Europe is still, the second wave is horribly, in the US and all around the world. I think Australia is at the moment, we're very lucky. We have 0 cases and we are in an excellent bubble. So I'm thinking of the rest of the world. I think at the moment, a lot of the focus is on acute care and the recovery of those who had corona. But I think next year, we're really going to start seeing more the consequences of inactivity, isolation. So whether it's mental health or chronic diseases or sarcopenia, I really think that's going to be one of the focuses. And I really hope that everybody then can react to that. What we sort of thought for next year, so the webinars really have reached, because we've reached now 1,500 people. So we're sort of hoping to continue the webinars next year with different topics, slightly different protocols. So exercise medicine is definitely one of the big topics we're going to be talking about. So we're really going to choose maybe a bit less speakers and different topics. And we really invite all of you, watching, please send an email to us and say if there's a topic that really is a key area for you. I think personally exercise medicine is a key one. So really talking about, and we've sort of lined up a few people already secretly for next year, also including a general practitioner, because I think that's often like all of you, like Catherine was saying, correlating and cooperating with other people. I think we really need to spread the message and start working together. So this is the reason why we've had different speakers. We've had nutritionists, we have had exercise physiologists, physios, we've had researchers, we've had managers, we've had clinical, hospital, rehab, home care. So we really, with our webinars, we're really trying to bring everybody together, because what we've learned is that this is the best way of talking to everyone. So if you go to a conference, you have a small audience of experts of a particular field. Well, the webinar really allows us to talk to everyone and have a conversation and have an engagement for everyone. With this final word, it is time for me to thank you for being with us for the whole year. The webinar started as my crazy thought when I was stuck in quarantine after returning from Europe to Story. I was there and returned through the closed airports and slight panicking world. And when I was stuck in my room for 2 weeks, this was the ideas, like, hey, what can we do? So I'm very thankful that I know awesome people that I've invited to talk over this time. So great 12 speakers. I'm grateful to you all, and I'm so impressed what a big audience we've reached. Thank you all. And all I can do is say happy holidays and welcome 2021, and may it be corona-free, or may it be COVID normal, and let us all be happy and healthy and bring on the wellness and hurry up with the good job. Thank you to absolutely everyone. I think it's time we wrap up 2020 and get on the festive spirits. Thank you, everyone, and we'll see you next year. Bye.